Good evening, ladies and gentlemen who have joined us on this Dr. Fundi Digital Health channel. My name is Dr. Fundi Lenyati, a qualified family physician and healthcare entrepreneur. Today, I'm wearing a different hat. I am the host of this healthcare channel. We have a very interesting, conversation over the next 45 minutes. Our focus today will be on matters of national importance. We are going to feel for a pulse of the South African healthcare system. Who better to inform us about the state of our healthcare in South Africa than the National Minister of Health, Honorable Dr. Zwelini Lawrence Mkhize. Utwabe, ukhabazela, kamavovo, kazihlandla, ukubhela, usingela, wena wasembo, wena okhanya amasi esuswini. Now, that's how we welcome people in the African way. So I'm hoping by doing so, I'm inviting, his underground crew to be here with him as we converse today. A little bit about our national minister. He is a qualified medical doctor. It's important for me to clarify this because early in the pandemic, some people were saying he is not a doctor. He is a qualified medical doctor. He qualified at the University of KwaZulu-Natal at the age of 26. And, he was born in Willowfontein in Pietermaritzburg. Now, the same university, that he's an alumni of, he was a chancellor there for a period of 8 years. He's currently the National Minister of Health since May 2019. Before, he had been the longest serving MEC of Health in KZN for more than 10 years. And he's been a premier of KZN between 2009 and 2012. He's been an MEC of Finance and Economic Development from 2004 to 2009. Honorable Minister, Dr. Zwelini Mkhize, welcome to the Dr. Fundi channel. If you can unmute yourself.
Thank you very much, Dr. Fundi Nyati. Ngapha ngakitho Nyati osindane, onyati emnyama. Very, very grateful to have the opportunity to converse with you tonight. And thank you very much for a very kind introduction. And we look forward to the conversation. And I take it's a conversation just to try and understand a lot of things that are taking place as we speak. I think all of us have got the concern that we are going through a very heavy pandemic that has really given us a huge amount of pain, suffering, and losses of lives of very close people. And we have to now work together to say what is it that can be done to deal with it, and where are we and how are we going to be facing the future. So I thought that your conversation was very, very important. Also coming from the background where you are, family practitioners are actually very, very important. And in our system, and in particular our future system, they're going to be the backbone of the national health insurance, which is a system that is about universal health coverage. So family practitioners and nurses, community nurses, and primary healthcare nurses, community healthcare workers, and that whole category of practitioners at the community level are going to be very, very important. So I think that these kinds of channels are important to share views and also to discuss what we see as we go forward. So I really want to say thank you for the opportunity.
Now, we have only 45 minutes, so I will get on with the questions. The intention of this conversation is really to create awareness, to inform and to clarify to the people of South Africa about various issues relating to our healthcare system in South Africa. Now, just to kickstart, I will just start with the healthcare system. Then we will zoom in to the issues relating to the COVID-19 pandemic and COVID-19 vaccination programs. So in about 3 months from now, Kabazel, you don't mind if I call you Kabazel?
Yes, please go ahead. That's actually much preferable.
Yes, all right. In about 3 months from now, you will be finishing 2 years after you've been appointed the National Minister of Health in the current administration. Now, I thought let's start there and say, with the previous incumbent in your position, there was a time that he said the South African health system was in ICU. I'm not sure how serious he was when he said that. However, now that you will be finishing 2 years within the portfolio, with oversight, over everything that is done in healthcare, nationally and also the provinces, how would you characterize the state of the health system in South Africa?
Well, I think we should say that it's a health system that to a great extent is effective. However, it has got challenges that need to be attended to, and it can be improved to a much better situation than what it is now. As I came in, I looked at it, and I had a number of areas which I believe need to be given attention, and that becomes work in progress. And I believe that is a kind of work which, even if we were to start fixing now, it's going to take us a long while to be able to get them corrected to the level which we need to ultimately accept as the best care that we have available.
Yes.
Then, firstly, I think there's an issue of the dichotomous system of a private and public sector. Yes. The private sector is well resourced, but we think it's got its own challenges. The Health Market Inquiry report did indicate a number of weaknesses on that system. Yes. It is working, but it's got challenges, and not least of which is the issue of inequity in terms of the distribution of the available resources across the two systems. Nevertheless, it's working, but it is something that needs attention. Then the public health sector is basically responsible for healthcare to 84% of the population. It's really underfunded. It needs a lot of investment. And so to be able to deal with the infrastructure that needs to be upgraded, quite a lot of infrastructural upgrading is needed, an expansion of the infrastructure. Then the issue is human resources, where we need to increase the human resources, both to be able to fill in existing vacancies in the current establishment, and also to focus on a futuristic establishment that gives us the kind of quality care that we need. Then, of course, the need to strengthen the aspects of management, which also has to be done. Very significant, the significant issue about it is that you need the kind of capable managers at a facility level, right up to a level of provincial as well as divisional, sectional heads of the department. Then you also have the issue of quality of care, which is a very important issue, because that basically is what everybody wants to see. When you walk into a hospital, it can't be so dirty so that you start feeling that you'll be sicker having gone in there than you would have if you had not been there. So the question of the entire spectrum of what quality means, from the basic issues of cleanliness, efficiency of service, available linen, food, and all of that, right up to the kind of compassionate care that people must get when they get into the hospital, where you feel that you are warmly received, you are warmly managed, comforting environment, and all of this, where you go into a bed, you've got someone to look after you, and the sheets, the linen, the bed linen, and all of that is all managed properly, and all of that, and the system that's efficient, where things don't fall into cracks, as it were. So that's another aspect. And then linked to that is to then deal with the question of reorganization of the system. The entire system needs to be organized with a very strong referral system that allows people to be treated at the appropriate level of care. So someone who needs to be seen by a nurse can be seen by a nurse and be satisfied. And then if, of course, the situation is complicated, needs to be referred to the physician or the family physician, and then to a different level of speciality, depending on what the situation is. That will even off the weight or the burden of managing the patient, the care. And that way you then are able to distribute health information, health knowledge, so that people can themselves take responsibility for their own health. And then every level looks after people who are appropriate for that particular level. And then I think all of that together must be able to take us to a national health system which is well funded, which is well organized, which allows us space to be able to deal with the burden of diseases, where we can target to say, in this area, how do we make sure we can do enough work to prevent the diseases so that people don't end up in a hospital unnecessarily, where you are also able to balance up the health services together with the socio-economic development issues that are very important determinants of good health and improved life expectancy. So that is how I would look at it.
Yes. Now that was part, of your 9-point plan, which you shared, when you were having the budget vote and the policy statement on the 12th of July in 2019. Now,
exactly.
Yes, and how have things gone so far? It's only been 2 years. Obviously, some areas have gone, there's been more improvement, some areas maybe lagging a little bit, but just overall, in the 2 years that you've been there, have you seen improvements in the various legs of the 9-point plan?
Well, I would say that things were coming on very well, because we had then focused on discussing the issue of the financing of health services. And therefore, we started a whole discussion around investing in infrastructure. And that work is not complete, but quite a lot of projects have been activated. But at the same time, we still have to correct some of the historical lagging of the projects, where, for example, some in Limpopo have got construction of hospital that delays, and because of contractual issues and so on, which really does create a problem. But nevertheless, there's been some progress in that regard. Then the other area becomes the area of human resources. We've also worked quite hard to make sure that we increase the numbers of people who are employed, and also close as many vacancies as can be done. And we've actually passed a new human resource strategy, which is basically saying, where are we, where we should be, and therefore we must start looking at how to implement such a service. Then we have also started the program on the training on quality of care, which is also very important, that people must understand that you don't need to compare with anybody else. You compare with yourselves in terms of what quality of care you're offering, and you must keep improving on what you've already been doing until you are able to get to a point where we can say that the kind of quality of care in this particular area is quite acceptable. And then also strengthening on the primary health care. In particular, we have to try and organize the community health workers and solve some of the problems that are associated with that, so that it becomes a stable cadre of health workers at the grassroots level. But also, we also wanted to integrate additional programs to the community health workers, so that it not only just focusing on TB, HIV, and so on, but now we have to start dealing with the non-communicable diseases, where, as I was saying, we needed to get a program where a community health worker can actually literally clock a patient and get the blood pressure and everything, and enter everything in. By the time it gets to the nurse and to the doctor, everything is actually there. You can literally make a diagnosis, because you can actually upgrade the level of training at that kind of cadre of services. So we were actually coming on well with all of that, and of course, then COVID derailed us quite a bit.
Yes. All right. Now, just back to that point around quality of care, and one of the key deliverables there was the Office of the Ombudsman, which, is occupied by Professor, Makhalepure Makgoba. Now, just a few weeks ago, he released a report around something that happened at the hospital. And I don't want us to get to the details of what happened there. Safe to say, from that report, it does show that, issues of quality of care are still issues in some of the facilities that need to be given, priority attention. What's your comment around, just the report that was issued by the Ombudsman, just as the National Minister of Health?
Yes, no, thank you very much. And you must say, just if you'll allow me just 1 or 2 seconds to go back on that history. A very, very sad story, because it was brought to my attention that somebody had sent a Twitter message saying that he had not had food for 48 hours. And I was shocked. And so I picked up this and I sent it to the MEC and said, look, what is this? How can somebody say they've not been fed, as it were? As we went to check the hospital, we found out that, in fact, the patient had passed, which was very sad, and may his soul rest in peace. Now, in that process, then the MEC went personally to the hospital and sat with the team and asked them, listen, there's this problem, what's happening here? He listened and listened and came back and told me that, no, look, this is what I'm getting. Then out of that discussion, the two of us discussed and said, no. There's something here which is amiss. Let's actually get a proper investigation. That's when I referred the matter to the Ombudsman. Fast forward, the Ombudsman has gone into the area, interviewed more than 100 witnesses, done a thorough job, a real thorough job in terms of investigation. Nevertheless, what this has exposed, firstly was that we must never lose the sense that for every file that you have to deal with in a hospital, it's a patient. For every patient that's in a hospital, there's a family. And you must always remember that for anything that happens to one person, there's a family that's in anguish, that's grieving, that's in pain, that's been bereaved. And therefore, that angle of care is very, very important. That don't just say, well, this one is past and that's the end of it, because the family needs a lot of care. In this case, there was quite a bit of need to deal with that aspect. And I was happy with the fact that they were able to attend to that aspect. The second aspect of it relates to the fact that it actually exposed a lot of things. You see, health workers are hardworking people. They're dedicated, they're committed, they work hard. They get out, or they go all out of their way to save people, to support people, to comfort people, and so on. But sometimes things fall into the cracks. Sometimes things go wrong. Sometimes somebody misses the ball. And so that, in this case, is what I think would have happened. And so it exposed weaknesses in management. It exposed weaknesses in the chain of caring. It exposed the issue in support services. It exposed the issue in the kind of compassionate care that we need to always be known for as being the trademark of our health services, that we are compassionate, we are caring. So it exposed all of these issues. And I felt that whilst it might be a very disappointing report, but it's important for us to take two issues to heart. One, that our health workers are doing a lot of good work, but two, there are instances where we actually drop the ball, and when we drop the ball, you need to actually act on that. And in this case, the actions that are being taken are fully supported by the ministry or by the minister, because we went through the report and we understood, and we went through several times to say what else could be done here. So I think it becomes a lesson which we must use, so that you can use as a test case that goes to all the hospitals to say, look at this report, and these are the things that we must correct, even though we don't know if they're happening in the other hospitals. But let's look out that no person must be exposed to this kind of care or lack of it that has happened in this case. It really is a very serious matter for us.
I think also, just on the same point, Kabazela, is the issue where a number of provinces, year after year have now been having to put up, contingency budgets, for these kind of cases. And that takes money away from service delivery to now have to, deal with these matters. And this is an issue that, has been raised, quite a number of times. You also raised it on the same, presentation in Parliament in the 12th of July, 2019. And so I think, like you say, it actually creates awareness to all stakeholders that this is a matter that cannot be allowed to continue. It needs to be at the back of everybody's mind, within a healthcare facility. Right. Now, and then one of the points within your 9-point plan was the issue of universal healthcare, which is national health insurance. Briefly, for people who don't understand what NHI is, if you could just share briefly what is NHI and why does South Africa need it, and maybe link it now to, COVID-19 pandemic. How have countries that have got universal healthcare fared in dealing with the issue of COVID-19 pandemic, as opposed to those countries that don't have, COVID-19, that don't have a universal healthcare?
No, thank you very much. You see, what COVID-19 has done, it has exposed all the weaknesses that you can ever think of in our system. It exposes the underfunding, it exposes the inequity, it exposes poor quality, it exposes the fact that our services may not be adequate to deal with the heavy burden of diseases. And therefore, the point I made about the need for a future increased investment, it becomes a case in point. Now, national health insurance is a system which is supposed to help pull together all the resources that we've got so that we are able to redistribute them in a manner that allows people to get the same quality of care, irrespective of whether they can pay for it, whether they're employed, whether they are rich or poor. But at the end of the day, ill health is something that comes onto the person. And in many instances, people have to decide whether should you take the money which you could have taken your child to school or bought food. If somebody is sick, you have to now go and spend that money. Now, the national health insurance, in our case, is looking at a mechanism of how we integrate our health system and then pull together all the resources, all the funds that are available within the system, put them all together, and then create a particular system that allows people to, who have got a particular level of illness, to be at a particular set of facilities, and then move to the next facility based on the fact that there is a need for them to get there, so that you can actually get, the basic care at a level which is at an affordable cost to the system. But you get the care without having to part with money directly at the point of service. But you can actually make a contribution. So what the system does, it allows people to make a contribution to the fund for the health services, and therefore those who have got a higher income will contribute more. Then those who have got less income will contribute less, which is in accordance to their capacity to contribute. And those who are unemployed don't need to contribute. And then it also allows that there's a kind of cross-subsidization, which we call social solidarity, which that means that the younger ones who are working hard, who have got lots of income and are healthier, they will not use the system as much, but they'll probably contribute more. And then when you get older, when you no longer can earn a salary, but you are more sicker, and all of that now means that society must now look after you. So it's a situation of saying you make a contribution so that the system can look after you when you can't look after yourself. That's what it's supposed to be. It means also that because we're all South Africans, we're going to carry each other. If I'm not well, I'll contribute. If I'm employed and I'm well, I'll contribute to the system so that those who are unable to contribute if they are sick, they should be looked after by the system, irrespective of whether they have been able to pay. So when you get onto a ward, in a ward where someone must go in there because they've got a particular abdominal problem, you can be in that ward irrespective of whether you are a businessman, a multi-billionaire, or you are an unemployed person. You'll be looked after by the same professor who has to actually make sure he gives you the same kind of care because of the same kind of disease that you've got.
Yes. All right. So now, just in the envisaged, NHI, what role, if any, is the private sector, supposed to be playing? There seems to be a lot of jitteriness amongst people who are in the private sector currently, around, the role, how are they going to be integrated in the system? Just if maybe you can just share a little bit around that.
Well, private sector is a number of different things.
Yes.
Let's take the private sector as it would relate to general practitioners.
Yes.
Now, general practitioners become the anchor of the national health insurance because they are kind of gatekeepers who will look after the patient and look at them in their own interest. And therefore, they will determine the level of illness that the person has, diagnose them, and then refer them appropriately or treat them where they need to be treated. Therefore, will help the system to receive at a higher level those who require that level of specialization that they refer them to. So they become, therefore, a very, very important team. In this case, we will have to ultimately have the support and cooperation of as many family practitioners as possible. If you talk about, for example, the United Kingdom, in the UK, there literally all the family practitioners are affiliated to the national health system, and their affiliation means that they are allocated a population to look after, and then that population, there's a budget for it. So the family practitioners will then be looking after the patients on the basis of ensuring that they stay healthy. They make sure that they get screened early, they get diagnosed early, they get referred early, so that early interventions will actually help to improve the lives of people. The shame with us is that if in the UK you can say every person can be accounted for by a family practitioner, in Cuba you can say exactly the same thing. In South Africa, there are large communities who have got nothing to account for them, not a clinic, not a family practitioner, nothing. So that needs to be corrected. So that's the one area. The second area relates to the specialists. Now, all the tertiary, all the secondary or regional secondary hospital hospital that offers secondary care will require a degree of specialization, and that degree of specialization will come from the same specialist that you've got. What is important is to be able to then contract as many of them as possible, so that they will then be part of some of them will be paid for by government directly. Others could be actually offering service to the NHI and be contracted on the basis of the services that they will render. Then, of course, the contracting mechanism is where there is always a bit of detail, because what NHI would then do is to look at item by item, and then look at how in a particular area there's an estimation as to how many of those operations are needed, and then come with a budget. So they will call out and say, in this region we're going to likely to do let's say 15,000 appendectomies, and therefore we will contract all these doctors, but we'll pay so much for the appendectomy, which is not the same as what's happening in the private sector. So in the private sector, you can charge a huge amount, but in this case, they'll give you a certain amount. The only thing that you'll be guaranteed of the volumes, because all those people will be coming to that particular service. So there is a role for the private specialist. Then there's a whole lot of other allied professions, right? Physiotherapists and so on. So that whole category have to be now linked to either one of the services, so that they are able to offer the services. If it's at a level of a primary health care, they have to be part of a multidisciplinary team that has got the general practitioners and some of those services. If it's at a rehabilitative care level, at a secondary or tertiary level care, then of course they'll have to look at how they either do work directly or they're linked to the specialist care that gets offered at that level. Having said so, then we then say there were lots of talks of people who were saying, oh, we know the specialists are going to leave the country and so on. We said there was no need actually for them to leave, because what really happens is that in the countries that they are likely to get to, they'll actually find that there's an NHI of some sort. And therefore, it's important for them to understand that we rather sit together and build our own and then continue to get the services, because we need all those services. Then the next lot is what we would call the private hospital groups. Now, what we will be doing as we're going towards the national health insurance, we will then be saying that the facilities need to be accredited based on the quality of care that they need to offer, but also there's going to be quite a need of ensuring that they are integrated into a system, a health network in a particular district, so that those who will be able to accept the terms of the national health insurance will be contracted in if they qualify. And so they can be contracted in and they can be working together. So, for example, I'll give you an example and say, if you have got district hospital, let's say in Wamhlabi, you have got so many district hospitals which are all doing a lot of good work, but you now want a certain degree of tertiary care or specialist care of a certain level. Then you might then say someone who's a private hospital there could actually be contracted so that these hospitals can refer to that particular facility and therefore offer these services. Because they are a private hospital, we have to agree on a fee of how we're going to contract with them. Then the public hospital can refer to that or work together with that network. But it doesn't mean that if you are in Johannesburg Central, then you have got 35 super specialized private hospitals that we can all contract them all into the NHI. Not all of them will necessarily be contracted. So there'll have to be a question of reorganization at that level, because what we have seen quite commonly is that, people where they are, you don't have the services following people. The services follow revenue. So where are more, you are more likely to get more money, you'll find more private hospitals. Where you've got more need for hospitals and yet people are poorer, you'll not find many private hospitals. Now that is an anomaly that needs to be corrected. So even the way we deal with the hospitals, we need to be able to say, we will encourage more that you can put up your hospital in this area, then we can work together through the NHI, because we now have got the need for it. So there's a space for that as well. So a lot of these other services that are associated, like radiological services and laboratory services and so on, they will all be working on the same basis, on a need basis. Then, of course, then medical schemes will obviously need to be, they'll be modified, and somehow we'll probably end up with quite a bit of consolidation, because the health market inquiry pointed out that, there is no way of standardizing what they offer. There is no way of comparing like with like. There is no way of knowing why you should have one medical scheme offering so many packages which are not the same as the other package. There has to be a degree of standardization of the care and the offering that comes from the medical scheme. Now, once you do that, obviously, there'll have to be a framework legislation that is able to guide that process. So we will have all of those, but everyone will still have a role. But of course, they will change because of the way the national health insurance will have to be organized.
Yes. Now, then we had COVID-19 coming in last year, 2020, and here in South Africa on the 5th of March, we had our first case. Since then, we have seen how this pandemic has affected, the national pest. So the question, therefore, that I have with you, Kabazela, is with those plans that were quite advanced for NHI rollout, we were told maybe around 2026. I'm not sure if it's still like that. And having listened to your presentation on Universal Health Day, Healthcare Coverage Day on the 12th of December, there were two schools of thought. Other people, are thinking that, okay, because of the financial challenges of COVID, this thing has to be shelved. But some of the advisors to the department were actually saying this is the best time to actually introduce. Maybe I just wanted you to talk around what has been the impact, and does this mean shelving of NHI, or does it mean, actually fast tracking the process?
Yeah, it's actually a very, very important discussion that the COVID-19 has exposed all these weaknesses. And COVID-19 has made it clear that in future, South Africa will have more difficulties dealing with pandemics and health emergencies unless our systems are properly structured, sustainable, and resilient. And therefore, it's important for us to move closer towards universal health coverage so that whatever challenge, whatever pandemic, whatever health emergency that befalls our country, it must find us much more organized, with more equitable access, with more quality of care, with better distribution of healthcare workers, with better resourcing of the health services. Then we'll respond better, and we'll be able to save more lives. That way, we'll be able to save more people from the devastation of the particular pandemic. It does make a difference in countries which have got that kind of system already well organized, how they respond, because you have to respond on the basis of a system that must withstand a new stress on top of the previous burden of illnesses, diseases. Yes. Now, interestingly, though, COVID-19 started showing us certain things that we can do better. That, in fact, it's inevitable that we must go in a particular direction towards NHI. So the first one, which was important, is integration of our services. Now when we issue the results, how many people have been tested? We're not counting government hospital, government laboratories. It's all the laboratories. We sat down with a discussion and we agreed that there's going to be a common platform where everybody's going to report. And if we've got a problem, we'll go into that system and check what has gone wrong. When the numbers don't match up, now somebody from the government entity will go to the private laboratory and say, listen, we're not happy with your numbers, what's going on there? Unlike before, where everyone was for themselves. So that actually became a very important issue. And it actually made the country look much more respectable, because when we talk about health services, laboratory health services, laboratory services is a South African service, irrespective of whether this is a government, this is a private sector, and so on. And then we were able then to start sharing the load. When there was a pressure, the private sector had a huge backlog, and we had to move them out to the government department, to a laboratory, to go and clear. And vice versa, when the government started having a huge load, we moved it all back to the private sector to go and clear all those loads. And in the process, we found that, you can pick up a phone and talk to the CEO of a private laboratory, and they would go and correct the issue. They would come to you and say, listen, we've got a problem here. That actually is something that we have learned. Going forward, we need to continue to work together and stabilize that. The second one was the area of the hospitals, private hospitals. We ended up with a fear that the public hospitals were going to run out of space to treat some of the patients, especially ICUs. So we had a meeting where we were to get an agreement across that we're going to refer to the private sector. And in the context of all of that, we had to set the prices to say, for this, for that, this is how much we're prepared to pay as government. There was no fight, there was no problem. We agreed, everyone was happy that there was a clear framework of how we're going to do it. Then the other way happened. Now, in the second wave, the situation turned the other way. There were more problems in the private sector than in the private sector. So we ended up with a lot of patients who were having medical aids not being admitted in the private hospitals. They had to be admitted in the public hospitals and so on. But what is the issue? The moral of the story is that you are sick. If you're South African and you're sick, it doesn't matter whether you went to the public or the private, you need to be treated. And that is, for me, the future that we need to actually cherish as we move forward. Then the other issue linked to that is that the case management, the question of standardizing the protocol of treatment. You know, you would have a general sense that if someone has got COVID, this is what they would have done in each or other of the hospitals. You have a slight variation here and there, but that standardization of protocol became a very, very important issue that I think as we move into the future, it helps us as well. So I think that we need to, build on this, kind of cooperation and partnership that has been developed. You know, when there's a complaint, somebody raises a complaint and he says, I wasn't treated well in such and such a place. I look around, what's this place? Don't know, it's a private hospital. I pick up a message and I go straight to the CEO and say, hey, listen, there's a problem here, please look at it. They immediately respond and come back and say, listen, we'll investigate, we'll tell you what's happening and come back. So, during COVID times, it was lovely working together. And I must say this. So going forward, we must find a way of how this spirit of cooperation, because it is clear that's how we can survive. And so moving forward. So I would say COVID-19 has shown the worst of our weaknesses, but also helped us to build on new strengths.
Yes. Now, let's get to COVID-19 itself. We obviously, in the African continent, we have the highest number of confirmed cases, both in, confirmed cases in terms of the disease, but also the highest number of people who have unfortunately passed on. We've had the first wave, we've had the second wave, and we are now getting to the lower point of the second wave, obviously worrying about the third wave, coming. Now, looking in the last almost, year since the pandemic, what would you say has been the learnings, besides what you've just said now, that is, the cooperation between private and public? What are other lessons, have been learned, which will be very good for the country going forward? And maybe another question, there will be other pandemics into the future. How can we make sure that South Africa is better placed and more self-sufficient to be able to, manage the pandemics going forward in terms of, research into vaccines, us producing our own vaccines, PPEs, and many, many other, things that are critical for a country to respond to a pandemic like this one?
Yes, certainly. I think it's a very important thing for all of us to look back and look at the lessons. One of the clear lessons which we need to understand is that the difference between the health services and the community programs is that for individuals who are afflicted with the disease, the healthcare system is where the management, that's where we defeat the disease.
Yes.
In the health institutions or healthcare workers, that's where we defeat the disease.
Yes.
But to defeat a pandemic, you need to understand that it's more than one person sick. It's the behavior, it's the trends in the community. So it is important for us to learn a lesson that, one, we need to invest very strongly on protection of our health workers to make sure that they can save each and every person who lands in their hands, but also we have to carry our community along to make sure that they can behave in a manner that's going to help to defeat the pandemic. Therefore, it makes it important to have a very structured response, which is one led centrally from the government, integrating all levels of government to the lowest level, as well as other sectors. So a multi-sectoral response is most important. We've seen how businesses have had to come on board, how in the private sector, how labor had to come on board, civil society had to come on board, and traditional leaders, religious leaders, and so on. If you leave any of those sectors out, you lose the battle at the community level, which is where you actually stop the pandemic. And at the same time, if you don't protect your health workers, you lose your battle where you need to save each and every life. So that for me has been one issue that's important, which means therefore it takes us back to the issue of understanding the need for us to ensure adequate investment in the health services, but to also carry our people along and leave no one behind. The second aspect of it is that it has also exposed the need for us to rebuild our health facilities, but there's been another challenge in terms of innovation, research and innovation. This area has actually come out in different ways in South Africa. So the need for us to be on top of the game in terms of researching the conduct of the virus in the pandemic, researching the conduct of the community, researching the needs, all the tools we need to be able to respond to this and find easier solutions. And it therefore becomes important for us to look at what we need to do to make South Africa to be self-sufficient in being able to respond adequately. 90% of all the PPEs that were needed for purposes of responding to COVID-19 were actually imported. Now that actually exposes the country very badly, because if you've got a pandemic, which is the whole world, then everybody begins to look at the resources for themselves. So if we don't have a sense of self-sufficiency in providing our own diagnostic tools, develop and manufacture in South Africa, some of the pharmaceutical products, medicines, also in South Africa, medical appliances and surgical appliances, vaccines, all of those issues now need that we must begin to, learning from COVID-19, build as much as possible of that pharmaceutical manufacturing base, so that we don't get caught up like that. So right now there are issues of vaccines. The continent of Africa has got 1.3 billion people. About 780 million of them need to be given vaccines. They need to be to have treatment and so on. Not a single of those countries is manufacturing diagnostics and not manufacturing vaccines. Now we need to change that, so that Africa as a continent must begin to be on its own self-sufficient. So it has actually opened our eyes and given us a bit more courage to actually venture into the area of vaccine development, pharmaceutical manufacturing, research, development, and the increased investment in those areas.
Yes. All right. Now let's just get now to the issue of vaccination. It was good to see you, Kabazela, amongst the first people being vaccinated. I think it was on Wednesday, if I'm not mistaken. And also we saw the president being vaccinated. And for me, that was a good start because there's been a lot of question marks around, are we going to be able to do this as a country? And also, obviously, the unfortunate situation with the AstraZeneca vaccine that then got to be found to be less effective, meaning a change. Now, just looking at the plans that you had as the national department with your advisors, how are things going in trying to roll out this vaccination program with a moving target, a virus that is mutating, that is bringing up new strains and all of that, So I just want to get your sense, the plans, because we've got 70% of South Africans, almost 70% that need to be vaccinated by the end of this year. Are you confident that we will be able to do that? What lessons have been learned?
Well, this was a very tough call. In the first instance, we've been traversing a very uncertain territory where not all the vaccines not everything was known about the vaccines, and we had not been able to invest early enough to secure a space in the manufacturing companies. So when we started getting involved, obviously, like a middle-income country, we didn't have as much of the resources. So we started engaging with the various manufacturers, and we then hoped that with the results that were coming, that we would actually have the best of guesses when we got AstraZeneca. And as fate would have it, we had a new variant that suddenly changed the course of history. So all of a sudden, we're now confronted with, here are the doses that we wanted to start dispensing, but at the same time, we've now got these results that are suggesting that more research is needed, because we had actually presentation from professors from Oxford in London who were telling us how this AstraZeneca vaccine was. Extremely impressive behavior all over, except here with this variant, it really had a bit of a challenge. So we felt we needed to go and change that. Now, because of that, we had a plan that was going to make use of most of these 1.5 million vaccines ahead of we actually thought within about a month or 2 months would have disposed of all of them, because we were really going to go out and push, and all of them, 1.5 million, we're going to give them a first dose for all of them. There was a hope, in fact, there was an arrangement to get a second 2 million, which we didn't talk too much about, but it was going to be coming as well towards the end of February. So we would have been covered already. Just on the health workers, we're actually in line about 3.5 million doses. So we're going to do the first batch, finish it hopefully within about 2 months or so, and then have enough to be able to continue after that. Now, of course, we had to hold all of that within a very short space of time and look for an alternative. Now we've got the alternative with this Johnson & Johnson. So the start is going to be a bit slower. So we are now going to actually start to revise our program. But where we are, from where we started, we must say that for us, it was a huge achievement that we were able to get the alternative on time, and therefore it has already landed and we've started. Even if it hadn't landed, then we were still waiting for it in another week or so, it would probably not have been as bad. But I think the anxiety we all had as South Africans because of the surge, the wave was too devastating, and we lost just too many people. And so everybody was very anxious that there must be a solution, and that's on the basis of which we actually acted. Now the processes have started now. We're pushing to get as much as possible of these vaccines, but there are now 2 plans in motion. The first plan is the one that is actually being driven by the Medical Research Council and the Department of Health, which is going to dispose of the first 500,000 of the Johnson & Johnson. The way it is arranged is that we're getting 80,000 every week, but there is a commitment from the, so that will take us up to about 300,000 of the doses. Then we've got a commitment from Johnson & Johnson that they were going to find the additional 200,000 on top of that. So that's how we're working on it. Now, the way they went all out of their way at Johnson & Johnson to go and make sure that these vaccines are available, even today I still remain very appreciative and grateful to the work that they've done, both from the point of view of the Johnson & Johnson led by Dr. Paul Stoffels and the entire team were available for us literally twice a day sometimes, and late in the evening, and they were prepared to do everything that needed to be done because they could see South Africa was going through a very difficult time and they wanted to help. And of course, Medical Research Council with Professor Glenda Gray and the entire team, they did a lot of good work. And Dr. Buthelezi and the team, it really became a very strong team that actually delivered what we've just seen. So things are coming on well. Today and tomorrow, they're actually vaccinating general practitioners and people from private hospitals, because everybody must be vaccinated. So we are hoping, therefore, that we will go on with this, and then in sometime early March, we should be able to get another additional doses that will come now from Pfizer. And those doses will actually start as well, with the health workers, until we can make sure that we've covered the health workers. Then we will then start receiving what comes from the manufacturing manufacturing companies. Those doses will come in late March, early April, and when those come up, we will then move away from this plan, which is now driven by Medical Research Council, to the original plan that had all the sites throughout the whole country, and therefore we'll get that into motion. So I think that it has worked out well for us, and we will just ask people to, respond and come in to do as much as they can to support this vaccination. I've been very impressed with the trade union leaders, but they're also health workers. So they came up and then in large numbers as leaders, they went in front and they're leading from the front. And of course, we're most grateful for President for also going through and taking this vaccine, because some people were not sure it is true that this vaccine is real. Others are saying, hey, just be careful. And then, but now the president
others say 666.
Oh no, I think we need to understand that people's beliefs have been tested in this situation. And we need to explain this thing, very sensitively, that it is not quite what they've seen in the Bible. What we're dealing with here is something that we can manage together. That, the 666 fears, yes, maybe that because what the Bible says, that we understand that, but for purposes of what we are going through, we do need people to go through vaccines. We can't just say that these are the diseases now that are going to be coming because this is just about the end of the world and so on. There will still be more pandemics coming. I mean, we've just still reeling from the HIV pandemic as well. So but we can manage them. And I think it's important for people to understand that, somebody asked me a question, do I think that the AstraZeneca results were because Chief Justice Mkhize had actually prayed that there should be no vaccines from the devil. Now, I think we need to make it very clear that there is no vaccine from the devil amongst the lot that we've got. And it's important for people to understand that, we may have all the beliefs and the stories and so on that we're here, because it's a new thing and everybody's very nervous not to be said to be a guinea pig. We're not doing any experiments now. We're actually giving people something that's been confirmed to be safe, something that is confirmed to be effective, but something that the whole world is doing. And so people mustn't think that there's any plot to kill black people and so on. Well, if there's a plot like that, I mean, the president is in the forefront, and there's no way a leader of government can actually put our people through a threat, because you are government because of the people. So it's important to understand that, these stories, we must just, understand that there'll always be debate, there'll always be discussions, but we understand some people are really believing that there's something untoward that might come. We need to assure everyone that it is safe. We have gone through it, we've taken it ourselves, and we're also trying to apply for more leaders to come to the fore, so that more leaders, some of the professors, I was talking to one of the professors, and who had taken the vaccine. So I said to him, how are you? And he was so excited and so grateful and so on. I said, you see, people need to understand that even those professors won't risk their lives by taking something that could harm them. And also we need more leaders to be allowed to actually get more exposed. Now, we will make that arrangement as we move along, because we've made sure that whatever we do, it will not compromise on the vaccines that were meant for the health workers, so that it must not seem like we're getting people to cut corners. We just want to make sure that people are assured that it is not as dangerous as some of the beliefs, some of the concerns, some of the stories, some of the information is making it to sound like.
It's been 72 hours since you actually had that jab. Any major side effects? What have you felt since you got that jab?
To be honest, all I got was a slight pinch. Of course, the nurse is very, very, very gentle. I mean, I've given injections. I've been given injections before. She was very, very gentle. Now, nevertheless, the last pinch I got was when the needle touched my skin. After that, I couldn't tell that they were done with the injection. So I've forgotten completely where the site of if you say I must touch where the injection went, I can't point at the site. I can just say in this area. In other words, the pain was minimal, slight discomfort, really, real pinch. But then there is no problem. I've not had any reaction, and I'm just normal. And I called the president to say, hey, Mr. President, I just wish to know how the president is feeling. And he said, of course, I'm well, and there's no problem. There has been instances where we've had, some people have reported some mild symptoms, some a bit of a pain, some a bit of an itch, others where, you know, we're feeling, well, I can't feel my body too well. They sit down, they settle, and so there was nothing major that so far has happened. At this point, we've gone beyond 6,000 people who have been given injection. I'm sure by today we'll be probably very close to 10,000 people that would have been given. What I've also liked is how many health workers have registered. I've not checked now. It moves so fast. This morning we're at 460,000 who had registered. Now you can imagine, those people, we must have now 460,000 doses to give to them. They're ready. By the time we get to next week, the number will be much higher. And so that, for me, the enthusiasm of the health workers is, again, also quite unbelievable. And they call, they send messages. Everyone is so happy because it's the one way we can protect our health workers, and they appreciate it.
Yes, yes. Now, in the initial plans of the department, you know, in terms of the vaccines, we were looking at, I think, 4, Pfizer, Moderna, AstraZeneca, and you know, also J&J. But now there's been some changes, and there are other vaccines that have been found to be effective, like, you know, the Gamaleya vaccine from Russia and the Sinopharm from China. Now, being our partners in BRICS, are we going to be engaging with them in any way, maybe for them to also assist with getting these vaccines? Because people in the Middle East are actually making use of those vaccines already.
Yes, we are actually going to be getting a range of the vaccines from a number of players. Right now, the discussions have been going on with Moderna, and there's some discussion there. China, we've had lots of discussions to a point where we've actually even signed what we call non-disclosure agreements, so that we can ask them more questions, that they give us more answers. And so they've also been guided to register with the regulator, SAPRA, and so that process is going on. And once that happens, we're hoping to procure some from Sinopharm as well. They already offered to give us about 2 million of their doses, and so we said, let's go through all this process and try and seal that deal and see where we go. Then we also have started discussions with Gamaleya Institute. Now, Gamaleya Institute, this is from the one that's doing Sputnik V. Now, very interesting, it's come up with very high efficacy, and but it's got a number of other issues that must be discussed among the scientists. But we have also got the process on the regulator. It's been initiated, and in that process as well, there have been suggestions of certain trials that need to be done because of some of these issues I say are with the researchers and scientists. So we're encouraging that there must be good working relationship. There is a decision which was taken by the BRICS summit that we should support the creation of a BRICS Vaccine Institute in South Africa. So Minister Blade Nzimande has been assigned as part of a team to lead a team of ministers to look into this matter. So we're working together in that regard. And so we hope that with time, the necessary announcements will be made when they are ready. But we are very clear at this point that we will try and get as many of these vaccines available as possible so that we are able to get the flexibility we need. If we think that in this setting, this might be better, in that setting, that might be better, and so on, we're just basically saying those vaccines, from the various players, we will engage with everyone and make sure that we don't leave one particular manufacturer behind, because this is all new. We just want to be sure that we can also do our own observations internally to say this one works better in this setting, that one works better in that setting.
Lovely. That's very reassuring. And now what I just want to also just find out, Minister, is the second phases, phase 2 for essential workers and people in aggregate communities and people with comorbid disorders. So the plan is still there to get to that phase 2, and then later to everybody else who's 18 and above, which is phase 3. Or are we also looking that we may spill over to next year?
Yeah, it's possible to spill over to next year. It depends on how much the vaccines, how well they're supplied. If they slow us down with the supplies, it might force us till next year. It is possible also because I've seen some of the well-resourced countries have been complaining that they didn't get their orders. So we will obviously have to fight our way through in that process. However, phase 2 and phase 3 are still there. Original plan was phase 1 was supposed to take us 3 months. Phase 2 was supposed to take us 6 months. And 6 months, it's about 16 million people. And phase 3 was supposed to take us another 3 months, because then it would be everyone else after that. However, what we're trying to do is to see that, you see the advantage of Johnson & Johnson is that in the other vaccines, we would have done the vaccination twice. So as in my case now, I won't need a booster. I've already got one. So those who will get Johnson & Johnson will come in once. That means, therefore, the numbers of people who we will reach is going to be much higher if we use Johnson & Johnson. And then the numbers of those who will need double doses will be reduced by that number. So we're trying to get as much of the Johnson & Johnson as possible. And so I will only announce the numbers once we've got the agreement closed. Then we'll see that, in fact, as we speak now, we've probably got we've got enough vaccines in this pipeline to be able to cover the 40 million that we spoke about, in fact, more. And that means, therefore, that we will continue with the plan. But what we're trying to do is to get the plan such that we must complete before 3 months, the first phase, and start the next phase at the same time whilst we're completing. Because once we've got enough vaccines, you can wait for the numbers of people who will need a second dose. They're not going to be many. So we must start. You can start actually as soon as possible. Then we can then structure the doses. Now, excuse me, what it means, for example, what we have seen in the UK, they've done the Pfizer 1 dose, first dose, and then 3 months later, they do the second dose. They say it works. So we'll check those things. So which means if we've got a supply every month for the next 3 months, so you can vaccinate the first time people for 3 months. And then on the 3rd month, you start going back to give a second dose on the first one. So it allows people to start building immunity anyway beforehand. So then we would like to see some of these phases overlapping. And for me, we need to make sure our system is so strong that it's able to take more people. Because ideally, anyone who gets onto the vaccination center should not be delayed. You must get a vaccine and come back when in due time.
Just one last question, because I'm worried about time. Your spokesperson had put strict time frames. Now, just a question around the Moderna and also the Pfizer one that require extreme cold chain. Do we have that capacity as a country? You've just mentioned that we're also looking to get Pfizer. Do we have the capacity, and will those be used more in the major centers where maybe there could be better, facilities, and maybe not much in the rural areas?
Yes, we do have those fridges at minus 75 degrees. We didn't know. Initially, I thought this was a big problem until we found out that there are lots of research institutions that have got that. So they are there. Secondly, we've seen private sector companies that have said, listen, we can make this capability available. So we think that we'll find it. Thirdly, the Pfizer, for example, has said, if we say to you, we're going to give you 7 million vaccine, we're not going to give them to you as a batch, 7 million one time. So we're going to give you every so many weeks, and so maybe a month, so many weeks apart, which means the smaller amounts that will be coming to us. So it will be easier to manage them. Then they took us through a packaging of how they do it. The packaging, for example, has got preservative case that you can put a battery on and it can last 48 hours without any interference if you don't open it. So all of those issues are taken care of, but the cold chain will be protected and there will be no problem whatsoever.
Beautiful. Now, Kabazela, you and your dear wife, you informed us that you got COVID some months ago. Now, at a personal level, how are you feeling? Have you fully recovered? Are there any long COVID, type of issues? Just to reassure the nation that, the man at the forefront of our pandemic, is actually okay.
Well, thank you very much. Thanks for asking, and thanks for the concern. I must say that both myself and my wife, we're fully recovered. But I must thank South Africans. The amount of support, messages of good wishes and encouragement that came from South Africa was overwhelming, and we really do want to say thank you very much to all our fellow compatriots for the support that they gave. And I wish that everyone could be given the same amount of encouragement and support. We are aware that there is this phenomenon of a long COVID where you just don't quite recover. Your energy levels, you feel weak, you're lethargic, and over a long time, you don't really feel you're back to normal. We didn't have quite that. We actually recovered within about 2 or so weeks. And so, but you feel it. You feel something is different in your body, and really we need to understand what people are going through, the pains that they go through, the weaknesses they go through, and all the changes in their body that they go through. And there are those who you think are recovering, and it just drags on, and then they ultimately succumb. So all of those are the complexities that we take into account as we're saying, let's get vaccines so that we can improve protection. So thank you very much for asking. We are much better, and we really do appreciate the support from all fellow South Africans.
Now, a few, people who do surveys have found that there is almost a third of the people who were respondents in those surveys who are hesitant, about vaccination. Now that you've taken the vaccine, I just want your closing remarks in encouraging South Africans to positively consider vaccination, even though it's a voluntary matter.
Yes, we have faced a very difficult 2 waves of COVID. We've lost many lives. We've lost many relatives. The only way we know how to protect each other from this COVID is to use the vaccines. The vaccines are safe. The vaccines have got efficacy to be able to deal with the virus. We would like to plead to all South Africans to take the vaccines. I have taken the vaccine. I am well. I really hope that all of us will take the vaccines and protect ourselves and protect our South African nation. Thank you very much.
Kabazela, thank you, Honorable Minister. We could talk for so long, but unfortunately, this is your family time, and we can only take so much of your time. So I want to thank you. I want to thank the people who are in your office, Dr. Lwazi, Jackie, and other people who made it possible for us to have this conversation. So I want to really, really thank you, and may you have an enjoyable weekend further, and may you continue to lead this country as far as this fight versus COVID-19 is concerned. You have done a sterling job, so far, and there's nothing that says things will be different going forward. So thank you very much. We are appreciative of your skills, your knowledge, your ability to bring people together, and ability to take advice from those who are experts. Thank you very much.
Thank you very much, and keep up the good work. Really, congratulations on a beautiful platform. May you all use it to keep sharing information. But thanks very much for this conversation.
Lovely. Thank you very much, Minister.
Thank you very much.
Thank you.